So good evening to all of you out there from all over the world. It is my pleasure to welcome you tonight to our UNNA Academy webinar on the topic of non-aesthetical indications of botulinum toxin A in dermatology. My name is Shirin Kehanian and I am the team lead for the global medical experts here at USERIN. And before we start with this interesting webinar, I have just some privacy policy remarks. So this session is recorded, and we as Bayersdorf, if you register with your full name, can track that you have registered for this webinar and for how long. We can also see your name when you are asking a Q&A in the Q&A session via Teams. But of course, you can at any time object to the processing of your data by sending us an email and contacting us. Just briefly, some words about the UNNA Academy. So let's remember that the clinical benefit of the patient must prevail. This was the guiding principle Professor Unna followed all his life. And this is also the reason why the UNNA Academy was named after him. Because the mission of the UNNA Academy is to really put the patient in the center of everything we do and to increase the treatment outcome for the benefit of the patient by offering high quality and innovative trainings from experts to professionals around the topic of skin. And the training topics offered by the UNNA Academy cater to your interest and to your needs and are really independent of corporate interest and products. So this is a very important point and topic for the UNNA Academy. I would like to draw your attention also to our international website. We have recently uploaded many trainings there from all over the world, from the local UNNA academies. And this really is like the building on the idea of sharing the knowledge across the globe and creating an international UNNA network. So please be welcome to have a look there and enjoy the trainings we have online there. So the training session today is dedicated to the topic of non-aesthetical indications of botulinum toxin A in dermatology. And Dr. Hassan Galadari is our UNNA Academy speaker, and I just would like to shortly introduce you to him. So Dr. Hassan Galadari is based in Dubai, but he did his residency at the Boston University in the US, and he's an American Board Certified Dermatologist. He's an assistant professor and consultant dermatologist at the College of Medicine and Health Science in UAE University. And his main area of interest is cosmetic dermatology, particularly the field of soft tissue augmentation. And he has also published a book, which you can see here as well on the slide, which was translated into many languages. And he has lectured in numerous international congresses. He has published many publications in peer-reviewed journals, and he's really an expert on the field. He's giving us a training today. So, welcome, Dr. Galadari. The stage is yours. We are very happy to have you. And you can now share your screen, please.
Excellent. I can finally share my screen. This is a first for me. I mean, for the first time, I'm not really at home, as you can see. I mean, I would love to have a home like this, but apparently the decor here is really fantastic. So it's a little bit different than something that I would usually decorate my home with. I am speaking to you live from Dubai. I'm going to be sharing my screen very soon, as soon as I'm able to. Are you guys able to see my screen? Excellent, finally. All right, good. All right, so my name is Dr. Hassan Galadari. Thank you so much for the warm introduction. Thank you for the people of Bayersdorf. Thank you for the people who have invited me from the UNNA Academy to have this CME accredited session on the use of botulinum toxin for non-aesthetic uses. I mean, we are used to, as dermatologists, we're used to having botulinum toxin mainly for cosmetic reasons, but with this one, it's going to be something that's a little bit different. Personally, this is something that's very near and dear for me because I want everybody who's here after I am done able to exactly know how to inject these indications that I'm going to be discussing. So, without further ado, this is my disclosure slide. However, I have no conflict of interest with regard to this session, and whatever it is that I'm going to be discussing today, some of them are going to be considered to be off-label use. I'm definitely going to talk about on-label stuff, but at the same time, there will definitely be off-label use of the use of botulinum toxin. As mentioned earlier by Shireen, I do have a textbook that is out there called Soft Shell Augmentation, and that discusses more or less on fillers and has been translated into language. Let's talk about the history of botulinum toxin. Everybody talks about botulinum toxin. They want to understand what is the history behind it. How did this molecule that we have been using for many years now as dermatologists, as plastic surgeons, as all of the neurologists even, how is this molecule, how did it come to be? And for us to really truly understand that, I'm going to take you on a trip down memory lane. So this is the history. In the 1820s, the botulinum toxin was known as the sausage. It was known as the sausage disease because what happened is that people who were eating sausages developed some form of botulism. Either this came out today's book, it's called botulism. What happened is that their muscles were slowly starting to relax to the point that they developed respiratory problems because of eating infected sausages. A German surgeon later on came up to be pointed out that this was due to the effect of bacteria known as Clostridium. Now, the Clostridium itself, he identified the type of bacteria, and because of that, was able to point out that it was the bacteria that you caused it. And the way that he figured this out was he kind of looked at more or less an epidemiological kind of point of study, in which what happened is that people were going to a church for worship. There was a feast at that time. Everybody started eating that quantity of sausages, and what happened was that a few days after, everybody became sick, and hence, after going back, he figured out that it was due to the effect of the actual bacteria. However, in modern times, what happened to is more or less in the 80s, in which one doctor was Alan Scott. He was an ophthalmologist.
Sound is bad. I'm trying to fix it.
Sorry, I understand there's a
with the sound. Can you guys hear me now? Is it better? Is it?
Perfect.
Okay, great. I apologize for that. I mean, we are in a different setup. We wanted to kind of show you a different place rather than just me looking at a screen. I basically look at me as a whole. So Alan Scott, who was an ophthalmologist, identified that molecule known as botulinum toxin that was produced by the effect of Clostridium, and believe it or not, sold it for a very small amount. They sold it for about $5 million for a bigger company known as Allergan. So his company was Allergan, and he sold it at that time. And hence the reason why there was a huge boom after that, especially in the late 80s. If Alan Scott kept the actual shares of this company, he would have been an extremely rich person at this point. However, it wasn't until the early 2000s in which there were indications for the use of botulinum toxins that were pointed out as both cosmetic in addition to therapeutic reasons. And the therapeutic aspect, there's going to be a whole list. We're going to be talking about a few of them. These will include hyperhidrosis, migraine headaches, TMJ, pain. In addition to, I'm also going to touch a little bit about depression. Okay, so that's basically the history. So in 2002, this was when botulinum toxin, or UNNA botulinum toxin, was first approved for cosmetic reasons. In 2004, primary axillary hyperhidrosis was approved by the FDA. In 2009, able botulinum toxin, because there are different types of botulinum toxin, which we will talk a little bit more about as we kind of move along. Able botulinum toxin was approved for cosmetic reasons in addition to cervical dystonia. In 2010, UNNA botulinum toxin was first approved for the use of chronic migraine headaches. In 2011, botulinum toxin now came about to be, and it was pretty much used for the treatment of cosmetic reasons, such as, for example, the glabellar lines. In 2013, there was UNNA botulinum toxin was approved for the lateral canthal lines, and in 2019, botulinum toxin was approved. Now, botulinum toxin is the latest kid on the block. These are all the different FDA-approved toxins that are out there. This is what you're seeing. And every column now, you can definitely see the differences between the two, all of them. The first column, the botulinum toxin, its trade name is Dysport, produced by Galderma. It's a little bit different than the others. If you look at the complementing protein, it's made up of anywhere between 500 to 900 kilodaltons. The actual toxin itself only consists of about 150 kilodaltons. The botulinum toxin, which is produced by the German company Masseteric, trade name is Xeomin, only contains the actual toxin. So it's only made up of about 150 kilodaltons. It does not contain the complementing proteins. And then you have UNNA Botulinum Toxin, which is, this is what everybody knows as Botox, which is produced by Allergan. And it has a 900 kilodalton complementing protein. And finally, Botulinum Toxin, which is in the United States, that is distributed by the American company Evolus, known as Jeuveau. However, everywhere else in the world, for example, in parts of Asia, it is known as Nabota, which is manufactured by the Korean company known as Daewoong. So all of these are available here in the UAE. If people out there are from Europe, the only one that is not available yet is Botulinum Toxin. So Botulinum Toxin is not available yet in the European markets. However, it will be soon. They are working on receiving their CE approval. All right, so what is the mechanism of action? So before we start off, we have to really truly understand what is the mechanism of action. How does this toxin actually work? And it's very simple. The way that it works is that it works in the presynaptic nerve. So if you have the nerve, if you look at the whole of the nerve itself has the axon, and at the end of the axon, just where at the end is, there's the neuromuscular junction. That's where the actual toxin is going to work. It is taken up through endocytosis in the axon, and then it works by inhibiting the release of acetylcholine in the presynaptic nerve fiber. If acetylcholine is not released, what happens is that it does not work on the receptors that are found in the skeletal muscles, and hence pretty much what we want to call, we don't want to call paralysis, it causes relaxation of that specific muscle. It works for a certain period of time. Okay, now this process, once it works, it's an all or none process. Okay, it is dose dependent, but it's an all or none process. There's nothing that will kind of let it go. And however, it definitely kind of tends to go away with time as the actual axon starts forming little smaller axons to kind of conform into the neuromuscular junction. And the effect of the acetylcholine then through the presynaptic nerve fiber gets back to its normal production, and then it gets released in the presynaptic synapse. So what are the clinical applications of the toxin? For cosmetic reasons, this is what is available. So you have UNNA Botulinum Toxin for these are FDA approved indications. They're used for the glabella, the crow's feet, the forehead lines. Botulinum Toxin is only for the glabella. So if you're using Botulinum Toxin for anything else on the face for cosmetic reasons, it is considered to be off-label. Botulinum Toxin is for the glabella, and Botulinum Toxin is also for the glabella. So the glabellar, your frown lines, are the ones that everybody gets an indication for in terms of cosmetic. The non-cosmetic ones are this huge list over here that you're saying, and I'm going like, oh my God, that's a big list. Okay. This list is so huge, okay, that it comprises many things and many different specialties. Whether you are a neurologist, whether you are a urologist, whether you are even a gastroenterologist, okay, all of these reasons in which you can actually use, botulinum toxin for, there is a number of indications. However, for the talk today, we are going to be talking about indications that dermatologists are able to use in their own practice. And I'm hoping that, given by the end of it, everybody's going to be able to kind of tell this is how we are going to be treating our own patients. The indications are so huge. Yes. Yes. Plus. Here. Okay. The indications are so huge that Time magazine put botulinum toxin, at that stage it was Botox, put it as a cover of its January of 2017 issue. So that's basically how it is. And it pointed out about 793 indications that the actual toxin is used for. Some of them are in the pipeline, others are not yet set. So, but that's how it was. So popular, they called it as probably the biggest discovery since penicillin. See how penicillin basically came about to be. Botulinum toxin is considered to be, as at that stage, something very akin to it. So the first non-cosmetic indication that I want to talk about is something that is FDA approved for the use of the toxin, mainly UNNA botulinum toxin, and it is for hyperhidrosis. Now, hyperhidrosis pretty much is a disease that affects the eccrine sweat glands. Okay, so some people usually have that, and that can either be familial, so some people, it runs in families. Sometimes it could be associated with other systemic problems. For example, thyroid disease. Okay, other conditions that can lead to hyperhidrosis will also include pheochromocytoma. Okay, but for this sake over here, we're talking about idiopathic, or primary axillary hyperhidrosis. Now, it's usually caused due to the effect of an excessive sympathetic activity, meaning that there's a lot of fibers, sympathetic fibers, nerve fibers, that are shooting in the area, more or less in the axilla at this stage. They're shooting, they're releasing the acetylcholine, they're affecting the eccrine glands, and what happens is that you are sweating for too much. Nobody really knows exactly why that happens, okay? So some people basically get it, some people don't get it, but they've pointed out that it is pretty much familial. 2.8%, so about 3% of the population suffers from this focal hyperhidrosis. So a lot of people actually, we're talking a big group. So out of 100 people, you have at least 3 who have that problem, okay? I, for one, have that problem, and I, inject myself with botulinum toxin to control it. It is so common that it causes a lot of social stigma, and at the same time a decrease in quality of life. Imagine yourself, I'm wearing black right now, but imagine yourself wearing colors, okay? Especially if you're a woman, if you're wearing colors, and you can definitely see areas in which there's excessive sweating, for example, underneath the underarms. And that causes a lot of embarrassment. So a lot of times people do not kind of conform into different social attributes. They don't want to kind of stay outside because of this, okay? Hence the reason why there was a necessity to actually treat this condition. So the sites that is usually affected will include the axilla, okay, because it is one of the sites that are there, the palms, the soles, and the face. Believe it or not, even the face can actually cause that, can have that effect. At the same time, also the scalp. A lot of people also start sweating out of the blue on their scalp, and you can definitely use botulinum toxin for the treatment of this. And I wanted to show you how we tend to do that. So there's a dramatic effect on the quality of life. Okay, so this is something that you have to kind of take into consideration. In most circumstances, as I mentioned, it is primary, so it is idiopathic in nature. Okay, secondary causes will include metabolic disorders, febrile illness, if you have, for example, high fevers, okay, and medications. There are certain medications that are cholinergic in nature, which will actually cause you to sweat even more. There are 3 forms, more or less. One is emotionally induced. So you're basically angry, something kind of ticks you off, and all of a sudden you start to sweat. Or, for example, if you are afraid in a social, and that's the reason why it causes a problem in social circumstances. So you're at a party somewhere, and what happens is that you start to you see your boss who's out there, and you're like, oh my God, and you start to sweat, okay? And there are many circumstances, so that's emotional induced. It can either be localized and also generalized. When I talk about localized, it can either be in the axilla itself, or generalized can also affect different parts of the body. Anybody who presents to you having primary axillary hyperhidrosis, you have to rule out other causes. And the other causes I mentioned will include the thyroid problems. And hence the reason why everybody who comes in, if they have an issue, and this is the first time I see them complaining of axillary hyperhidrosis, I will have to check a thyroid function test. I want to make sure that their thyroid is okay, so they don't have hyperthyroidism. I would want to check blood glucose levels, because higher glucose levels, even low glucose levels, such as hypoglycemia, can also cause you to sweat the most. Urine catecholamines, if you are thinking about pheochromocytomas, but however, that can also have other features that are associated with it. Uric acid, and also a PPD. PPD is usually checked, or sometimes you can now check a quantiferon. It's because TB, tuberculosis, can actually lead to night sweats, and a lot of people develop that effect. So you want to rule that infectious problem out before actually giving them such treatment. So primary hyperhidrosis is usually a study, more or less, that looked at a multi-specialty working group on hyperhidrosis defined it as such. It is focal, it is visible sweating for at least 6 months. And usually the cause is at least two of the things that I'm going to point out right now. It is usually bilateral, relatively symmetric. Sometimes you can have one side a little bit more than the other, but pretty much it's usually symmetric. They have an episode of at least one per week. Okay, so they're all of a sudden they start to sweat, at least one per week. Impairs daily activity, and that's very, very important. Okay, whether it's going out, or sometimes even if they're if they have palmar hyperhidrosis, they are unable to use a pen. They feel that they cannot shake people's hands. So there's definitely some problem that's associated in terms of social, some social ineptitude that they're unable to fulfill. The age of onset usually is less than 25 years of age. It happens in the young. The youngest patient that I've injected botulinum toxin for at that, which was primary in nature, was somebody who was a girl who was about 9 years of age. Okay, and she was unable to go to school because she could not hold a pen because she was sweating all the time. There's a positive family history, as I mentioned, and usually there's a cessation of sweat when a person sleeps because it is the effect of a decreased sympathetic, nervous system. So because of that, what happens is that everything starts to cool off during nighttime. Hence the reason why we have to check quantiferon to rule out, for example, TB, which causes night sweats. Okay, so that's basically how primary hyperhidrosis is defined as. So during the consultation process, this is what you have to ask your patients. The first time, how many times do you need to change your undergarment? This is extremely important, okay? You ask them, some people will say, I only change it once. If they tell you that they change it once, that's pretty much normal. Okay, so, kind of points out that they probably don't have a problem and maybe they're exaggerating it. Okay, so that's one thing. So, but if they're changing their undergarments many, many times, I mean, they will tell you, for example, every hour I would need to change the undergarment, then, then there's definitely a problem that's happening over here. Because imagine you're outside, you are unable to change your undergarment unless you carry it with you in a suitcase. Anyone else in the family has a similar problem because, as I mentioned, there is a positive family history. In most circumstances, some people don't, but in most circumstances, they can have a positive family history. Is there a trigger? Remember, we talked about emotionally induced. Is there, for example, if it's a student, the person gets asked a question, do they start sweating at that stage? Or, for example, if they are doing an exam and they're using, for example, a pen and then they start to sweat. So there's anxiety that causes that to happen. So is there a trigger? Or, for example, they're watching TV and their favorite football team is losing. Okay, so there's a lot of things that that can trigger this to happen. And finally, you have to ask, how is this condition affecting their daily routine or their daily lives? If it's not affecting them, then you have to rethink about why are they here to begin with. The reason why we see our doctor is that if there's a condition that causes us to have problem, so you have to kind of think about whether this problem actually exists or not. So that's the last question that you have to ask. And finally, of course, you have, during your history taking, you want to make sure that they're not taking any medications. So you found out a patient, he or she has hyperhidrosis. What is it that you're going to do? First of all, you have to make sure that they're sweating. And for you to assess that during a physical examination, you have to do the iodine starch test. Now, the iodine starch test is a very simple test, and anybody can learn how to do it. Sometimes, now you become so skilled about this that you really don't have to do it, okay, if you're used to it. But if there is somebody who's out there who's never had or never done botulinum toxin for hyperhidrosis, learn how to do the starch test. It's easy. Get starch from your local grocery store, just regular starch, okay? And get also your iodine. And I'm sure if you're working in a clinic, you definitely have some iodine. If you don't, I don't know that. Yeah, I'm going to have to rethink what kind of clinic you're working in, unless you're a psychiatrist. All right, so you make sure that the area is dry, completely dry, the area that you want to test. Then you apply your iodine all over, and then you apply the starch. So you make sure that you can see it on the second picture over there. You apply the starch until it covers the whole thing. Wait, give the person some time. They usually, if they have primary hyperhidrosis, within a matter of minutes, not hours, within a matter of minutes, you're going to start noticing that there are certain pockets, small focal areas that will turn black. That area basically is the area in which they've got their hyperhidrosis. Now, that can cover the whole axilla. It can cover part of the axilla, okay? So you have to learn how to do the iodine starch test before treating anybody. Once you start getting used to it, you kind of know, okay? And sometimes you can actually see it. A lot of times with my patients that I'm seeing, I can actually tell that, oh my God, they're sweating right in front of me, especially if it's palmar hyperhidrosis or, plantar hyperhidrosis. So you definitely see the excessive sweating that's happening. So this is how the iodine starch test looks like. You paint the iodine, and then you look at the areas, those focal areas that turn dark or black, and that's the area in which there is excessive sweating, and these are the areas that you want to try to focus on. And then you simply start injecting, okay? And I'll talk a little bit about the dosage very, very soon. So you cover the whole area to basically the whole thing. If you're doing the palms, it's exactly the same. Okay. However, you have to cover the whole palmar area. You can use the iodine starch just for the palm, but that is not necessary. The reason for this is that the palms are much more sensitive in terms of how you're going to be able to visualize the sweat. The minute they start seeing the needle, okay, and that's coming close to their fingers, they're going to start sweating automatically, and you can see the sweating right in front of you. Okay, so that's more or less for the palmar hyperhidrosis. When it comes to reconstitution, if you're going to reconstitute for hyperhidrosis, I don't want to get into the details of reconstitution because this is, it's a completely different talk, but just make sure that you're reconstituting your UNNA Botulinum If you are using UNNA Botulinum you're considering it with 5 ml. Okay, so the reason for this is that it is not the same as the cosmetic reconstitution, which is usually 2.5 based on the manufacturer. It is 5 this time. The reason for this is that the higher the volume that you're reconstituting with, the more diffuse the effect that you have. Okay, so this is a given, usual. Okay, so that because there's a lot of volume that's there, it becomes more diffuse. In this area here, you want your toxin to be diffused to have a much better efficacy. Unlike, for example, if you're treating cosmetics, you want to make sure that you're hitting that exact muscle. So you want to make sure that your reconstitution is not too high. Okay, usually that's the reason why it's about 2 to 2.5. Now the dosing for the axilla, you would start off with 100 units. So you take the whole vial, which is 100 units of UNNA botulinum toxin, and you would treat 50 units on each side. Okay, you can go up to 150 to 200 units depending on the severity and the size of the axilla. A lot of people will say, how can we figure out the size? And I remember my mentor back in San Francisco, the way that he used to tell me, it's very simple. Look at the person's shoe size, and based on the shoe size, you'll be able to have a ballpark figure of how big his armpit is going to be. Okay? If you do not know, then I would recommend doing the iodine starch test, going back and doing the iodine starch test. It lasts a good 6 to 7 months. Now, in most circumstances, we usually tell, for cosmetic purposes, we usually tell our patients that botulinum toxins lasts usually 3 to 4 months. That's how it's approved, okay, 3 to 4 months. However, for the treatment of hyperhidrosis, it can last a little bit longer. And the more you do it, the longer it will last. Okay, so that's another thing. It's minimal amount of pain. So a lot of patients usually don't need anything, okay? And there's hardly any adverse events. I mean, less than 1% may develop muscular weakness. But if you are injecting, for example, the axilla, it's not going to cause any major problems. The problem is going to occur if you are treating the palms. If a person is a piano player or a guitar player, or if uses the keyboard all the time, or he's a surgeon. Okay, we're talking about a microvascular surgeon, and he needs to use his very fine motor skills. If you are going to use toxin on his palms, he's going to lose that fine motor skills. Okay, so you want to make sure that you take that into consideration before doing that, because it can definitely affect their area of employment. Okay, so you want to do that, and it is more than 90% efficacy in terms of how effective it is. It's actually very, very effective. It's a life changer for a lot of patients that end up doing it. If you end up doing it, if you have that problem, you do this, you're just going to really like the results, and the patients are always going to come back to you. Okay, the quality of life is definitely much higher than, for example, for cosmetic reasons. Palmoplantar, similar dosing. However, there's more for the sole just because the sole is a little bit larger. It is painful. Now, and a lot of people are going to ask me, Dr. Hassan, how are you going to treat the pain on the palms or the soles? There are many tricks, and if there's something that there are many tricks for, okay, that means it's not really very good. One trick is that you can ice the area prior to your injection. So you will have a nurse holding the ice on her, on the palms, and just before you inject, she moves the ice, and that's where you inject. That's one way. The other way is that if you have a vibrating instrument that vibrates the area just around it, and then you start to inject, that becomes a little bit tricky because it also does not allow you to become very focused on the area that you would want to inject. Imagine that the person's palm is vibrating and you're injecting them. So you have to be you have to really coordinate very, very well before doing that. So that's another trick. Some people will use topical lidocaine to help decrease the pain. That is not very effective because remember the palms and the soles especially, the skin there is extremely thick. Okay, it's not going to work very, very well in that area. And finally, you can do a block. If you end up blocking a person, just keep into consideration that this person for the next 2 hours is going to be stuck in your clinic, okay? Because if you do for the palms or if you do for the soles, they're unable to move them, okay? So, the patient and you are going to be stuck in clinic, okay? So if it's the last patient in your clinic, the last thing you want to do is to block him. In most circumstances, people ask me what I do is that I would tend to do the ice. That's my personal favorite. And I just talk to the patient the whole time, okay? I find that puts them a little bit at ease, okay? But there is no good trick in terms of treating hyperhidrosis. Now, other people will tell me, so you just talked about UNNA botulinum toxin. What about the others? We've got the other ones. So what about the INCO? What about the ABO? INCO botulinum toxin, I don't know about because it has not been pointed out or has not been studied for the use of hyperhidrosis, but I can tell you that botulinum toxin, there is literature out there that botulinum toxin works, okay? And this was, we did just recently publish a systemic literature review in the journal, the American Academy of Dermatology, just last August, okay? So this is an SLR that showed that botulinum toxin is quite effective for the treatment of hyperhidrosis. Again, this little graph talks about all the different types of dilutions and dosing that a person can use if they're using botulinum toxin. Okay, my personal favorite, even though I published this one, I've written this one. Okay, my personal favorite is UNNA botulinum toxin. So I'll just put it out there. It's much easier for me. Now we move to migraine headaches. And migraine headaches, I think we're good in time. Migraine headaches. So I'm sure a lot of people have had migraines in the past, and this is sometimes it can be so debilitating that they are unable to function. Now, migraine headaches, in terms of the reason or the etiology and why they happen, it's not really very well known. Sometimes people will tell you that they have an aura before getting the migraine, and it's associated at times for certain individuals with photosensitivity, and also not just photosensitivity, but also ocular sensitivity. They don't want to make sure, they want to be away from the lights, they want to be away from the sounds, and they just want to be in a dark room, okay, until the migraine goes away. In most circumstances, there are a number of medications for the use of their use in migraines. However, there are times in which that does not work. One of the reasons why a migraine trigger can happen is because it has been pointed out that it could be due to the effect of vessels that just tend to contract for some unknown reason or unknown trigger, okay? Sometimes it could be an odor, sometimes it could be a light, sometimes it could also be food that can actually trigger migraines, okay? So these are the things that are, that usually causes migraines. In 2010, UNNA botulinum toxin was approved for the treatment of migraines. And there are certain criteria that have to be fulfilled before UNNA botulinum toxin can be used. One, the person has to have a history of migraine headaches, and the headaches, which can include the tension type, has to occur on most days. They have to have an attack for at least 15 days out of a month. That means we're talking about half the month they have a headache, okay, and that's considered to be a migraine. And it won't less than 14 days, And if you have other types of headaches, such as cluster headache, tension headache, it can work. Okay, so it can work with tension headaches, but it can work and also with migraines. But with cluster headache, which is more commonly seen in males and most commonly, if require, for example, oxygen therapy, botulinum toxin is not going to work for them. The PREEMPT study group, and this was published here, developed an injection paradigm, and I'm going to go through it as we kind of move along, okay? And it was conducted, and it was basically looked at people with, migraine headaches and tension type headaches. And they looked at fixed injection sites and followed the pain of the injection sites. So this is how it is. You have to look at the areas in which have to be injected, and then you ask the patient where they have the headache to kind of inject it. So 100 units of UNNA botulinum toxin are diluted in 2 ml of saline, okay, yielding a concentration of about 5 units in 0.1. And this is something everybody knows. Okay, I don't want to go through the math. So it's 2 ml of saline in that vial, basically, with about 100 unit vial, in which every 0.1 is going to be about 5 units. Each intramuscular injection site is injected with those 5 units of UNNA botulinum toxin. These are the areas, so this is the paradigm. The frontalis muscle receives 20 units on 4 sites. The corrugators, 10 units on 2 sites. The procerus, which is just one, we have only one procerus, 5 units on 1 site. The occipitalis, which is right in the back, is going to be receiving 30 units in 6 sites. The temporalis, which is over here, is going to receive 40 units in 8 sites, and the trapezius is going to receive 30 units in 6 sites, and the cervical paraspinal, which is also in the back, are going to receive 20 units in 4 sites. So this is going to be a total of about 155 units of UNNA botulinum toxin that is applied. Okay, you can add an additional 40 units based on the area where the pain. So after you do this is known as the fixed sites. You have to treat them this way. Okay, and then you add 40 units based on if they have a trigger in one area that is more than the other. So they can receive a maximum total of about 195 units. That is safe. Okay, so in a sense, people with migraine headaches also get treated cosmetically, because if you're hitting the procerus and the corrugators and the frontalis, the wrinkles on their forehead is going to go away. These are all the different sites, as you can see them over here. So you got the frontalis, the procerus, the corrugators, the temples, and you can look in the back on the occipitalis, the trapezius, and the cervical paraspinal. Okay, and that little table over there, if you've got the time, screenshot this, because I want everybody who's finished with this to really know how to do this, because it's very, very simple. Just make sure that the person is diagnosed with migraine headaches. Unfortunately, a lot of neurologists don't inject botulinum toxin. Whether they're averse to it or whether they have better treatments for it, they are not really much into treating it with botulinum toxin. They will send those patients outside, or they will not even provide them with this option. So here, as a dermatologist or as a plastic surgeon, you are able to help them. However, you cannot diagnose the migraine headaches. The patient has to come with that migraine headache already diagnosed by your neurologist. So this is a two-way street. You have a neurologist and you have a dermatologist or plastic surgeon that kind of help each other out. Then we're going to move towards the Masseteric injections, mainly for TMJ pain. We're not talking about Masseteric injections for the treatment of Masseteric hypertrophy, so that's more cosmetic effect. So we're mainly treating it for pain. So TMJ dysfunction, in a 2017 paper in the International Journal of Oral and Maxillofacial Surgery, UNNA botulinum toxin on 77 patients with TMJ dysfunction, okay, had more or less both their masseters and the temporalis muscles injected. They showed that 77% of them showed that they had a beneficial effect. The pain that's caused by the TMJ gets much less. What is the dosing? The dosing is very simple. There are 4 sites on the temporalis muscle with 10 to 15 units into each temporalis muscle. So that's about a total of 30 units. And finally, you have 25 units in the masseter, total of 5 sites over here, okay, for a total of 50 units on both sides. Okay, it's a very simple procedure. Look at this slide, take a picture of it or screenshot it with your phone. I want to make sure that everybody who comes in who has been sent by their dentist with a patient with TMJ pain or bruxism, they're able to treat them safely. It's a very safe injection. Everybody, us dermatologists, we're able to inject the temples, and we do it all the time, and we're also able to inject the masseters. Okay, so it's a very simple procedure there. Another study that was published a little bit later on, so this was about 2 years back, but in the Journal of the Oral Medical Oral Surgery, showed 100 units was injected, okay, and 10 sites. 3 sites per masseter, so it's a little bit different. So it depends on which school you want to follow through, and 2 per temporalis. The dose may be increased up to 150 units, so you can go up. Remember, injecting at 200 units is fine. Believe it or not, children with cervical dystonia and strabismus, they usually get injected with much more higher than that. Anything that goes beyond 200, then you probably risk the chance of systemic manifestations of the toxin. But anything less than that, it's pretty much localized, and that's basically how it is. All right, and that's basically it. I want to mention neuromodulators or toxins for the treatment of scars, and the way that it does this is that it relaxes the muscles for the scar. So if you have an injury, or for a person who's had surgery done on the forehead, an area that is high dynamism, you can inject them with a little bit of UNNA botulinum toxin, and that can help the scar remodeling system. Okay, and the reason how it works is that it prevents the movement. As a matter of fact, now there's a study now that they're looking at not botulinum toxin type A, but botulinum toxin type E, which is shorter duration, usually about 4 weeks, not more than that, for the treatment of scars. Okay, but you can definitely use that for the treatment of scars. And the way that it's hypothesized that it works by decreasing the repetitive movement, wound stabilization, better wound healing, prevention of the wound widening, and decreasing the inflammation and fibrosis, erythema, and scar size. These are little examples. Look at this picture over here. You've got the control, which is on top, and the botulinum toxin, which is in the bottom. Look at the size or the width of the scar. The area that is untreated, the width of the scar is much bigger as compared to that of the area that was treated. Same thing with patients with cleft lips. Patients with cleft lip, if they were treated with a little bit of UNNA botulinum toxin, which is the one on top, you can definitely see that it is much less as compared to the group that was not treated with UNNA botulinum toxin, which is in the lower. What's the dosage for scars? Unfortunately, there is no consensus here, so I can't really tell you what's the consensus. Okay, but it can go anywhere between 30 units and 2 to 4 centimeters for the forehead, and a simplified use, basically, if you have every 1 centimeter scar, you inject 10 units. Okay, so you just calculate how big the scar is. If it's 5 centimeters, you can go up to 50. If it's 10 centimeters, you can go up to 100. So just think about it this way. Every 1 centimeter is about 10 units that's injected. So in conclusion, that's, it can be used safely for the treatment of scars and making them look better. The final thing that I wanted to point out is neuromodulators for depression. Okay, this is something that's new, out and about. I'm not expecting dermatologists to be able to do that. Okay, not yet anyways, but it is in the pipeline. As a matter of fact, Allergan is going to be publishing very soon a study, and probably they're going to seek an indication for the use of UNNA botulinum toxin for the treatment of depression. And it was on the news just about maybe 2 to 3 months ago. And there is a definite rising interest. If you look at all the different published data, there's a lot that is part more or less in pain is pretty high, and also psychiatry is also pretty high. Okay, and the way that it works, especially in pretty much depression, you can see all the published data is getting more and more and more. Okay, as a matter of fact, I just recently put down a systemic literature review also for the use of botulinum toxin in depression. It is currently, we're awaiting peer review, and hopefully it gets published. How does it work? It's very simple. This follows what is known as the facial feedback mechanism. It's to simplify things. If you are angry, if you're always looking depressed, if you're always looking down on yourself, you're frowning all the time, okay? You look at yourself in the mirror, you're looking at the way that you look, and that makes you even more depressed. So that's how it works out. It's much more complex than that, but that's how it is. Okay, if you put in botulinum toxin, what happens is that you relax the muscles, you're unable to look sad, okay, or you're unable to look angry, or you're unable to be frowning all the time. And what happens is that that feedback mechanism goes into your eyes, and then it kind of points out that, oh, I look relaxed, or I don't look so bad, and hence the depression gets less. Now, I'm not saying this is going to be a primary treatment for depression, because depression is much more complex than this, but definitely it can be used for as an adjuvant treatment in addition, for example, to your SSRIs or any other treatments of or antidepressants. And this is how it works, as I mentioned. So there's a facial feedback theory. There's a social feedback theory. If you inject yourself with botulinum, not yourself, but if your doctor injects you with botulinum toxin, okay, you look good. People around you tell you, look, oh, wow, you look really good. They kind of boost up your morale, and the social effect makes you also happy about yourself. And then you've got, this is also theorized that you can definitely have an increase in 5-HT, which is basically hydroxytryptamine. That goes up, neuroinflammation can go down, and probably the insular cortex can be modified in your brain due to the effect of the toxin. That can also cause a decrease in your depression. That is a work in progress. And, you know, I'm putting my finger on the pulse here, and hopefully by next time, maybe in a few more months, once we talk about this, maybe in another session, we will have probably more data on the use of botulinum toxin for depression. So what is the future? Maybe a longer lasting neurotoxin. How about a reversible neurotoxin? Remember, this is an all or none kind of process. I would love to have a reversible neurotoxin that is out there. If I have a problem with a patient, we inject them with something which is an antidote, it goes away completely. Liquid toxin is in the pipeline. So remember, we reconstitute our toxins. There are a number of manufacturers that are thinking of actually reconstituting the toxin themselves and handing it out to you. For them, it's much easier in terms of storage, also allows you to have better, pretty much standardized amount of dosing whenever it is that you're injecting your toxin. And probably topical botulinum toxin. There are two areas in which topical botulinum toxin has been used. The first one, this was for patients who are usually needle averse, even though really, in all honesty, it's not really that painful. Okay, ask a person who's been injecting himself for the past 13 years, it's not really that painful. But people who are needle averse, there are things that are being worked at. So hopefully we will have a topical neurotoxin. The first one that was out there, which is known as daxibotulinumtoxin, failed to reach its endpoints. Okay, when it was used for hyperhidrosis. Okay, but they're looking at it more or less for the crow's feet. And there was another company that was just recently purchased by Allergan for a big chunk of money that was also looking at a phase 2 trial for hyperhidrosis using a topical toxin. The last thing I wanted to kind of mention is daxibotulinumtoxin, which I just recently mentioned as a topical agent. That can be used. This is 150 kilodaltons with your stabilizing excipient. You put it together and you end up with daxibotulinumtoxin. Compared to UNNA botulinumtoxin, daxibotulinumtoxin is going to last double the number of weeks. So in both studies in which they looked at the exact same toxin load, they found that patients or the toxin or the efficacy lasted about 24 to 27 weeks, which is double the amount of UNNA botulinumtoxin. Okay, so that's going to be coming in the pipeline. So in any case, whoever it is that you're going to be, whatever it is that you're going to be injected, just make sure that the person who's injecting you is a professional. Okay, you don't want to make, this is at the end of the day is a toxin. Okay. A higher dose of it can definitely cause adverse events. If you remember, in 2004, there was a few people down in Florida who had an industrial strength botulinum toxin injected, and all of them ended up in the ICU with a respirator, okay, because it was given at such a high dose, about 500 times the amount that we tend to use for cosmetic and therapeutic uses. Okay, so just make sure that the professional is the one who's injecting you, and hopefully you, as professionals, now can expand your horizons and not just only treat your patients cosmetically, but can also treat them therapeutically. With this, I thank you so much for tuning in, and I thank the UNNA Academy for having me. If you do have any questions, we're going to start taking them, and you can also follow my social media handles if you have other questions that you want to ask that will go beyond this session. Thank you so much.
Thank you, Dr. Galadari, for this interesting and very exciting webinar and lecture. So we have the chat is full with positive feedback about this lecture. We actually also have some questions. Okay. I would like now to just shout out. So how often should patients have botulinum toxin for hyperhidrosis, and what are the side effects?
For hyperhidrosis. Okay, so for hyperhidrosis, usually it lasts, as I mentioned, 6 to 7 months. I have my patients come back and see me in about their 5th or 6th month, and I would have them injected. But I would tell them that it will last for much longer than their cosmetic counterparts. If the patient is already used to having botulinum toxin for cosmetic purposes, I'll tell them that for hyperhidrosis, it'll definitely last longer for them. But yes, ask your patients to come back and see you in 5 to 6 months, and or at the first sign of sweating. Believe it or not, sometimes it goes away and never comes back for some reason. And if that happens, they're lucky. But at the first sign of sweating, or anywhere after, between 5 to 6 months.
Thank you so much. The second question is, how frequently do you need to inject? Would microbotox with rollers work equally well?
So this is on cosmetic applications of botulinum toxin. That goes beyond the scope of this session. But if you want me to answer, I don't know if this is. I would rather have something that's more therapeutic in nature in terms of so we stick to the same message for the actual session. That's okay with you guys?
Mm-hmm. Good, thank you. You're also welcome to still ask your questions via the Q&A chat function of Teams. You can then publish them and also make them visible to the audience. And then we have another question. Can we use this treatment for acne skin and sensitive skin?
Yeah, no, this is an interesting question. So it's been used. There have been many reports out there for the use, not for acne, but more or less for acne rosacea. And also for the effect of flushing that's associated with acne rosacea. Now, I can tell you that there are published studies that are out there. I've tried it myself, following the exact thing that is written in the literature. My patients were not very happy as much as they were kind of mentioned in the literature, but it's definitely been published. And yes, you may try it, okay? But you have to tell your patients that it may or may not work. This is not an indication. It's not an approved indication, but it's definitely been published in the literature.
Mm-hmm. Great, thank you. And then another question, how much per side you need on the hands and axilla and feet?
Yeah, as I mentioned, I would start with about 50, so 50-50, that's a total of 100, and then build from there. The soles sometimes may need a little bit more, but every time I inject my patients, I will tell them to come back and see me in about maybe 10 days to 2 weeks, and if they needed that little extra, we can always add a little bit more.
Mm-hmm. And what about botulinum toxin resistance and how to avoid it?
That's a very good question. All right, as a matter of fact, just before coming here, I had a patient that I just saw in clinic that I've injected 3 times already, and it's not working. It's not working at all. I mean, it worked the first time I injected him. Then he came in after that, and now none of my toxins work with him. I've tried Inco, I've tried PRA, and I've tried UNNA botulinum and ABO botulinum toxin. Nothing is working on him. So antibodies definitely can pop up. Now, if they do pop up, you tell your patients, there are many ways to do this. You tell your patients that let's give you some time, anywhere between 6 to 9 months, even sometimes up to a year of nothing. Hopefully the antibodies tend to kind of settle down, and then you re-inject them and reintroduce the toxin for them and see if it works. In most circumstances, it can work, but there are also a few people in which that is it. Once they start developing it, it's not going, and that's very unfortunate.
There are more and more questions coming up. So what's your opinion on allergic rhinitis and botulinum toxin?
I have never tried it. I mean, I don't know if it's probably. I've read it. It's available in the literature. It's been published. I have not tried it myself, but I mean, it's definitely been published, and I would recommend everybody who's watching this is to do a Medline search, not Google. Okay, to do an actual PubMed Medline search. Okay, and find the actual study or the case report, print it out, and follow the methodology there.
And what about acne scar treatment with mesobotox?
So not acne scars, okay, but we're talking about scars. We're talking about scars and how we can prevent scars. Now, for the treatment of acne scars with mesobotox, the name, or microbotox, is simply a name that people have come up with the injection of a huge area of the face, with very small amounts of botulinum toxin, usually anywhere between 1 unit, maximum 2 units, not more than that. And at times it covers the whole face. So we're talking about maybe 100 points all over the face. Now, for the acne scar treatment, it is not as effective as other modalities, for example, such as laser treatment, or maybe injecting it, for example, with certain types of fillers, or even surgery for acne scars. So it is not as effective, and I would not put it as higher on the list as an option for patients who have not tried other modalities. I would give them the chance to try other modalities of scar revision first before actually giving them or providing that option of botulinum toxin injections.
And another question, your approach towards face hyperhidrosis regarding the dose and the level of injection in contrast to forehead lines treatment.
So it's very similar in that sense. So if you are treating the forehead lines, you will notice that the patient is also going to decrease the sweat. As a matter of fact, most of the literature that was published for the treatment of forehead lines, they looked at the sweat production in that area. And that's the reason why UNNA botulinum toxin is different than ABO botulinum toxin, because ABO botulinum toxin affects the sweating even more than UNNA botulinum toxin. So you would treat it the exact same way. However, in addition, you can always now add very superficial small aliquots all over the forehead. So you treat the frontalis with your regular dosage, and then you can add a little bit more, however, very, very superficially. Okay, because what happens is that the first one is going to affect the muscles. So the movement of the frontalis is going to become less. But however, you want to treat the eccrine glands. And that's the reason why you want your injections have to be superficial for the injections. How many injections you're going to be doing? Remember, you're putting a very small amount. So you're putting anywhere between 1 to 2 units, not even 2 units, usually 1 unit. And that little small aliquot is pretty much intradermal. Okay, so we're talking about, at least for the forehead, at least maybe 20 points of injections to get the best results.
Thank you so much. So, and the other question, what could be the cause of Botox effects fading faster than usual?
There are many. There's been many theories in which why that happens. One of them, we talked about them, which is the antibodies. So you can develop antibodies because of that. The other is due to the effect of the axon proliferation. So what happens is that if you block that axon, what happens is that the axon itself produces even more little small axons for the neuromuscular junction. That's the reason why it's been theorized that you will require, because now there's more plates in the neuromuscular junction, you would require a higher dose to affect all the different plates, okay? And the same dose that they've used in the past may not be as effective. Now, there are other people who are, negate this theory and say, no, the more I do the botulinum toxin, I've noticed the less I require with time. And the reason for this is that you develop muscular atrophy. So even though the nerve is probably getting these little small mini axons that are proliferating, the muscles themselves are becoming more atrophied. Hence the reason why they will require less amount to have, a much beneficial effect in the long run.
And now a very practical question. And do you change your needle after how many pricks in palms and soles area, as the needle gets blunt and it causes more pain?
Yes. So for therapeutic purposes, for example, and for hyperhidrosis, remember, you have to use your 1 ml syringes, or sometimes even a 0.5 ml syringe. If you're doing that, finish your 0.5 ml and that's it. Okay, but if you're putting, for example, you're using a 3 ml syringe, you definitely have to change your needle, because you're not going to be able to finish the whole thing in one setting, and that needle is going to retain its sharpness. But for example, if I'm doing hyperhidrosis, if I'm injecting, for example, 50 units here, I would have 5 syringes. Every syringe will have a fresh needle. Okay, hence the reason why it will keep that freshness effect. I've noticed that the syringe will kind of last about maybe 7 to 8 needle pricks before kind of losing its sharpness, depending on the manufacturer that's being used. And also, the sharper it is, for example, the smaller gauge needle tends to lose its sharpness faster than, for example, larger gauge needles.
And another practical question, at what angle to inject on the hands, 0 degree or 25 degree?
No, I go at 90 degrees, actually. That's me. I just go straight up. It's actually less painful, because what happens is that if you're coming at a 90-degree perpendicular, there's a less chance for you to hit any of the nerves. If you're coming in from the side, there's a big chance that you're getting and hitting the nerves that are running in the palms. So it's much better to kind of just go straight in, and it's just the tip that needs to go in. So I go in perpendicularly.
A question regarding tolerance. So is there any report about tolerance? Is it immunogenic in origin? Can it be attributed to impurities, and how can it be treated?
Now, so that's a very good question, because one of the companies that are out there, I'm not going to mention any names, we're being good here, okay, we'll tell you that our toxin is pure, okay, because we're only putting in 150 kilodaltons and we don't have any complementing proteins. Most of the times, the antibodies that you do develop is caused due to the effect of the complementing proteins, because you have proteins you're introducing into your body. The body has a chance to produce an immunological response to these proteins. So these guys will say, we're not introducing these complementing proteins, we're only introducing the 150 kilodaltons pure toxin. Believe it or not, the other competitor company did a study that showed that you can still develop autoantibodies or antibodies against the toxin itself. Okay, so the 150 kilodaltons, even though it's pure and there's no complementing proteins, you can still develop antibodies against toxin. Okay, so that's been so I would consider this pure aspect pretty much more of a marketing thing. People are not going to like this, or especially the other companies are not going to like what I'm saying, but it's actual science. Okay, so definitely they can develop antibodies even with the purified form of the toxin.
Great. So another question, Dr. Galadari. So botulinum toxin is approved for the treatment of axillary and palmar hyperhidrosis. What about facial hyperhidrosis? Do you use Botox for facial hyperhidrosis in your practice? I think you touched base already on that question.
Yeah, I did. I mean, I don't. I personally, I don't. I mean, I don't have a patient who has that problem, but there are people more or less that complain of scalp hyperhidrosis rather than actual face hyperhidrosis, and then they start dripping. If you remember this old movie with Liz Hurley, Bedazzled, that guy, there was one of the characters just sweat the whole time, and like there's got a whole thing. And the reason for this is that it's more or less coming from the scalp. Now the scalp, there's many published data for the scalp hyperhidrosis and can be treated, and it's very similar way. Remember, you are treating. Think about it this way. You have to know where which part are you treating. You're not treating the muscle, okay, because the muscle will affect the wrinkles, okay. You are treating the eccrine glands. And where are the eccrine glands? The eccrine glands occur in the dermis. Hence the reason why your injections has to be as superficial as possible.
And another question, a practical one, can we inject wrinkles and treat hyperhidrosis at one session? Won't the dose become very high?
No, I mean, I've had patients, remember, we're talking about cosmetic purposes. For cosmetic purposes, if you're injecting, for example, the whole face, the maximum cosmetic effect that you're going to get at one setting is going to be anywhere between 60 to 70 units. If you're doing the feet, you're probably going to be injecting in one setting about 100 units. That is a total of maybe 160. Say a maximum of 200. It is still considered to be safe. People with children, especially with cervical dystonia, problems in the neck, require much higher doses, and they're still okay. Okay, so they usually require anyway going up to 400 units of botulinum toxin, and they're still okay. Now, I'm not telling you to go and inject 400 units, but I'm telling you it is completely safe to hit the 200 unit mark. If you do that, then you really have to think about, do you want to go beyond that or not? Remember, the people who are injecting those pediatric patients are doctors who are specialized in the toxin. We are dermatologists, and we have to understand where our limits are. And 200 units is pretty much the highest that I would go. And this is a recommendation that I would tell everybody, is that try not to go beyond that, because you don't want to have any patients who have systemic manifestations of toxin overdose.
So thank you for all these questions. There are still some more to come. I think this shows how big the interest is in this topic. So one other question. If a patient was receiving 2 to 3 treatments of Botox and had no response, can we call this then already resistance?
Yes. So if the treatments were done and they are, like I said, my patient has had 3 The first one was he was, you know, he had a response, and then after that there was no response whatsoever. So yes, if they've had 3 episodes in which there is no response, then there is no response.
And can we treat eye ptosis somehow?
So that's a good question. So if you have there's eyebrow ptosis and eyelid ptosis. The eyebrow ptosis, unfortunately, you cannot do anything about. So you just it's only time. That's the antidote. It's time. You just tell the patient to go and, you know, wait for it. The eyelid ptosis, you can always give them clonidine eye drops, and they can use the clonidine eye drops to kind of open their eyelids. Now, that being said, it makes them a little bit more functional, but cosmetically is still there. You can definitely see the difference between the two sides. And so hence the treatment for eyelid ptosis is going to be clonidine and thyme. Okay, thyme is the best antidote, and it's probably the only antidote for toxin, unfortunately.
Mm-hmm. And another question from Lithuania. So thank you for an amazing presentation. When is the earliest point in time where Botox can be injected to scars, and how often? Can it be done simultaneously with Kinolog? Thank you.
So if for scars, the minute you do the wound, you're stitching the patient up, that's where you inject your toxin. So you do it immediately as you're doing the surgery. So you've closed the wound, you suturized it, you inject them with a little bit of botulinum toxin.
Then another practical question, the needle tip used for injection and the angle of injection. I think
I personally use a 32 gauge needle. I don't want to mention which company produces it, but they're very small. They're about 4 millimeters in size. It's quite short, and that's what I tend to use.
Great, thank you so much. I'm just scrolling down, like a lot of positive feedback. This we already had. Microbotox and rosacea treatment you already also answered. I think. Do you use topical anesthetic cream or regional anesthesia for hands and for the sole of the feet?
So the person who's asking the question probably missed out when I mentioned that. There are many options in which you can use. It's ice, sometimes pressure, sometimes vibration. You can use a topical anesthetic, though I find that pretty much useless because the skin is so thick here on the palms and the soles. And finally, you end up with blocks. But I mentioned that if you do block them, those patients are going to be stuck with you for the next maybe 2 hours or so. They're going to be unable to drive, and they're also going to be unable to walk if you're doing the soles.
And how many units do you use to treat hyperhidrosis on scalp?
Of what?
Of scalp.
Hyperhidrosis of the scalp?
Yes.
Okay, so it usually a little bit less than 100 units. So I would start off anywhere between maybe 70 to 80 units, a little bit less.
And where to inject for hyperhidrosis in the upper lip area?
So that's more cosmetic again. So if I answer this question, that means I've made a bad thing about the other person. So I would rather not answer.
All good, all good. There's like a case report where a colleague is mentioning that I had a patient with urticaria, like allergy and swelling at the sites of a botulinum toxin injection. Can I try UNNA Botox on her?
So hypersensitivity to botulinum toxin has been reported. Okay, it could be probably more or less due to the effect of the reconstituent that you've been using. So it's not the actual toxin, but it was probably the diluent that you're using. For example, if a person was using, there was one case of anaphylaxis shock, and that was due to the effect of when a patient was injected with, I believe, if I'm not mistaken, not albumin, but it was, I think it was, if I'm not mistaken, probably hyaluronidase or something of that sort. So they definitely developed an allergic reaction that was the only anaphylactic reaction that was mentioned in the literature causing the effect of botulinum toxin. So it's not the actual toxin that led to this, it's probably the diluent. More or less, it's the diluent that's the cause of this. So if that happened, probably change your diluent. So if you're using saline, don't use saline. I'm not saying, use, for example, bacteriostatic saline. If you use saline from one company, switch to another company and see if that saline probably might work with them at a much better effect. But hypersensitivity to the actual toxin itself is rare. It's been reported, but it's very, very rare.
And what is the recommended conversion ratio for ONA versus ARBO Botox?
Oh, okay, all right. So it's anywhere between 2.5 to 3 ml. So 1 unit of botulinum toxin, okay, is about 2.5 to 3 units of botulinum toxin units.
And from what age is Botox recommended?
For what?
It's not specified here, but
I mentioned for hyperhidrosis, the youngest patient that I injected was for hyperhidrosis was 9 years old. Now, botulinum toxin for cervical dystonia can be injected for 2 years of age. So you definitely have the pediatric population covered. So yes, just hopefully you don't treat their frown lines, because babies can be angry too.
true. And there was another question. How do you prepare the patients? Like, do you tell them not to drink any alcohol, or what are the measures you ask them to do before they are coming for their injections?
No, I mean, they let them come, and hopefully they don't have any. If they have, like, for example, an acne breakout, they've got a cyst there, so if there's some form of infection, I would not inject them. If they have atopic dermatitis, and it's inflamed, their face is inflamed, or they've got some type of hypersensitivity reaction, I would not inject them. So there are a few things that you want not to inject locally if the patient has. And I've just mentioned a few of them. Now, there are other conditions, for example, if the patient has any muscular problems or any neurological problems, for example, such as myasthenia gravis or Lambert-Eaton syndrome, also you do not want to inject them with botulinum toxin. You want to be very careful in those population groups.
Thank you so much. There was another question. Let me just check. Is there a risk between two Botox therapies more risky for developing resistance? So if the time frame is too short.
So exactly, the reason why people develop resistance to botulinum toxin is if they get injected, for example, with a lot of toxin. We're talking, when I mention a lot, maybe 50, 60 units, and then another time that they come to see you within more or less than a month, and you inject them with the exact same dosage. So that, I would tell them sometimes even less than 2 months. If you're injecting too much, about maybe 100 units in 2 separate times, less than 2 months duration, there's a higher chance for you to develop, your antibodies. So if a patient comes to me, they want a touch-up, okay, or they want, for example, to treat their hyperhidrosis, I would not inject them if I've injected for them cosmetically anywhere between 2 months if they come in for the cosmetic reasons. So they would come in for the cosmetic reasons, and then they come in for hyperhidrosis. I would tell them, no, you have to wait for 2 months until I do that for you, unless they're coming in the same setting. So if I'm doing their cosmetic reasons for whatever reason that they're doing, in addition to a therapeutic reason such as hyperhidrosis, I can do it in the same setting, but not separate apart within a matter of 2 months.
Okay. And how do you treat bruising post-treatment, face, underarms?
Time. Or tell them to eat pineapples. Pineapples contains bromelain. Bromelain helps. Or give them a cream. Patients love having creams on. Just give them an arnica cream or something. But usually, to be honest, it's going to be time.
Okay. And what about diabetic patients? Can your colleagues use a toxin for them?
Oh, absolutely. Yeah, you can. I mean, if they've got no neurological problems that are associated with their diabetes, then it's fine. It's completely okay.
Great. So thank you so much for answering all these questions. I would just also like to invite you to share your feedback with us. So I am just posting, if I manage to, posting a link where you can also give the feedback. If you like to give us a feedback to the session. So thank you so much, Dr. Galadari. This was a super interesting and super relevant session. It was an excellent presentation from your side. As I said, the chat was full with praise and positive feedback. And thank you so much also for your attendance, being out there as participants, and for asking all these questions actively. I wish you all a good night. Stay safe, stay healthy, and I really hope to see you at some occasion again. And please visit our UNNA Academy website. Thank you, Dr. Galadari. It was a pleasure having you.
Take care and good night.